Kalimera, Kalispera. Roxana Mehran here, recording this talk for my dear colleagues in my second home, Athens, Greece, the SMART trial, the 2025 updates. These are my disclosures. I was one of the co-principal investigators of the SMART trial that is sponsored by Medtronic. Very, very important to begin with is why did we design the SMART trial? No other trial has ever looked at the small annulus between two existing valve systems that are being used. So we're just inconsequentially just choosing valve sizes and what fits and not knowing if one is better than the other. And in fact, it's very, very important that in the small annulus that is much more prevalent in women, aortic stenosis is different in men versus women. There's no question that the outcomes with TAVR has a higher mortality. There's much important outcomes that have been shown with TAVI to be better. So, and we're going to see a lot more patients with small annulus with women. And could it be that it's the small annulus that is making these, having these negative results because our surgical colleagues are not doing root enlargement surgery because it's extremely it's a very, very complex procedure. The pathology of aortic stenosis in women is also different. There's actually more fibrosis than calcification. The remodeling is different. It's less adverse remodeling, more reverse remodeling and functional improvement. And these women are mostly older and with very, very high levels of symptoms as well as high-risk features. So the idea that we would focus on the small annulus in hopes to actually have answers for women was a real one, but also for men who happen to have a small annulus. What is a small annulus? Well, it's defined as the annulus area less than or equal to 430 millimeters squared. It's about 30 to 40% of aortic stenosis patients, more common in Asian patients, and a higher risk of AV gradients, being higher increased gradients after TAVR or SAVR. So that PPM, the patient prosthesis mismatch that is associated with worse long-term outcome is much more prevalent in small annulus. So the idea that we would go after and actually come up with a characteristic that would enroll many more women, about 90% women, was this SMART trial, a self-expanding versus balloon expandable TAVR in patients with aortic stenosis who would have equipoise to receive either a balloon expandable or a self-expanding stent, being randomized 1-to-1. Dr. Howie Herman was the principal investigator, and myself and Didier Cheche were the co-PIs together delivering these primary outcomes at the ACC 2024 and published simultaneously in the New England Journal of Medicine. This was a global site participations, 83 sites in 13 countries. You see the countries here. Unfortunately, Greece is not here for unclear reasons. We have to absolutely have you all there. But self-expanding versus balloon expandable, severe symptomatic aortic stenosis, small annulus, equipoise to receive either a balloon expandable or a self-expanding valve, randomized, planned 5-year follow-up with these two co-primary endpoints. The first being a non-inferiority endpoint for the composite of mortality, disabling stroke or heart failure hospitalizations out to 12 months, with the second co-primary endpoint being bioprosthetic valve dysfunction through 12 months. And that's a very, very important endpoint because that is what patients feel when the gradients go up. So the valve characteristics are here. You understand that the Evolute Pro or Pro Plus FX is a supraannular valve with the ranges between 17, 18 to 30 millimeters. Valve sizes 23, 26, 29, 34. A nitinol frame, porcine tissue, recapturable with tissue sealing skirt to reduce PVL. The competing valve would be the balloon expandable valve, which would be the Sapien 3 Ultra. Intraannular, most of the patients were Sapien 3 Ultra with the annulus range of 16 to 28 millimeters, with the valve sizes being different, as you see, 20, 23, 26, 29, a cobalt chromium frame, of bovine tissue and not recapturable with an outer skirt to reduce PVL. The two co-primary endpoints were met. We found and reached non-inferiority for the mortality, disabling stroke, heart failure, rehospitalization, composite clinical outcome, as you see here, and found clear-cut powered superiority for the self-expanding valve of the evolute valve compared to the balloon expandable sapien valve in terms of bioprosthetic valve dysfunction. This was a composite endpoint that was powered. We also had powered endpoints for HSVD and non-structural valvular disease, which was defined as a mean gradient greater than 20 millimeters for HSVD, and for the non-structural valve dysfunction, severe PPM according to the VARC-3 or moderate total AR. And we met that. The hypothesis tested the mean, these were secondary endpoint, hypothesis tested and powered for superiority. We reached superiority for the mean gradient being lower in the self-expanding valve, the EOA being higher at 12 months for the self-expanding valve, and of course the BVD in women, very important, being reached. This was a powered endpoint, as well as the moderate to severe PPM, all of them in favor of the self-expanding valve over the balloon expandable valve. These were all powered for superiority, and they were met. Importantly, the quality of life was also improved at 12 months with a difference of 7.2% better improvement in the patients with a self-expanding valve versus the balloon expandable valve. We also did this work with a very good evaluation, myself and Didier Cheche, first authoring this data in women only. And we found similar results, slightly lower clinical outcomes for women, but still not meeting statistical significance, really being normal, and the p-value being perfectly fine, no difference at all, but a very important reduction in bioprosthetic valve dysfunction through 12 months in favor of self-expanding valves in women. Also, we looked at alternative bioprosthetic valve dysfunction definitions, all of them meeting the superiority for the self-expanding valve. We also looked at this as the use of balloon expandable valve versus self-expanding, found it to be a multivariate predictor of bioprosthetic valve dysfunction, and it was consistent throughout the range of annulus areas in the trial. This is really, really important. No matter what size, in the small annulus, the balloon expandable valve did worse compared to the self-expanding valve for bioprosthetic valve dysfunction. We also found an important difference that has been submitted and will be presented in New York, was presented in the New York Valves by our team, many colleagues who have put large numbers of trials and looked at bioprosthetic valve dysfunction and its association with a 5-year worst clinical outcome. We do not have those 5-year data from SMART yet, but so far there doesn't seem to be a difference in the clinical outcomes. We also know that it is important that it takes time for adverse hemodynamics to come to affect clinical outcomes. You see the severe patient prosthesis patient mismatch taking a long time before you start to see the effect on the clinical outcomes as well as the gradients. And so we have 2-year data with excellent follow-up, and we don't show a difference between the clinical outcomes as yet between these two valve systems. Bioprosthetic valve dysfunction, though, still remains in favor. You see all of the data looks very, very similar, no difference at all in any of these parameters, but prosthetic valve thrombosis through 2 years, CEC adjudicated, seems to be numerically lower with the evolute valve compared to the sapien. Bioprosthetic valve dysfunction through 2 years remains superior for the self-expanding evolute valve compared to the sapien valve at 2 years, as does the EOA, mean gradient, and DVI numbers being better, all in favor of the Evolut valve. The total AR also looking at, as you see, very, very interesting and similar out to 3 years. So out to 2 years. So the take-home messages is that this randomized SMART trial compared the Evolut self-expanding and the Sapien balloon expandable TAVR valves in 716 patients, 87% being women with a small aortic annulus. At 2 years follow-up, we saw no differences in the composite clinical outcome of death, disabling stroke, or heart failure rehospitalizations. So we met the non-inferiority, but we haven't shown a clinical benefit as yet up to 2 years. But very, very important hemodynamic measures continue to demonstrate the superiority of the Evolut platform over Sapien platform for bioprosthetic valve dysfunction, superior at 1 year, superior at 2 years. And the very, very important comparison that will happen through 5 years will give us the answer if there is going to be an important association with this outcome and long-term follow-up. Thank you so much for your attention.